Good afternoon to everybody, and welcome you all to the combined clinic grand round. Department of Hematology will discuss about the APL or acute promyelocytic leukemias, changing paradigms from good to better. So, acute promyelocytic leukemia, as you know, is a unique entity in AML, especially AML M3, commonly known as AML M3. Most of the time, it is present with medical emergencies with acute bleeding episodes. It's not a rare entity, although it's uncommon. It's first described in 1950s as a hyper acute fatal hemorrhagic illness. Subsequently, we understand the pathophysiology of this disease, and also there is a changing paradigm of the treatment pattern from chemotherapy to non-chemotherapy regimens. So, with this background, we have also experienced for last 7-8 years PML. So this is the flow of our CGRs. The first half is part of pathogenesis, diagnosis, and molecular diagnosis, and coagulopathy, which is a major concern in APML, will be the lab components, and subsequently we'll discuss the treatment overviews and therapy and our experience in last 7-8 years. These introductions, I would like to invite my colleague, Dr. Jasmita, to start the proceedings. Dr. Jasmita.
Thank you, sir. I'll discuss in brief the molecular pathogenesis of APML. So it occurs because of a gene fusion between the PML gene and the retinoic acid receptor, PML and the RARA gene. They fuse to form the PML-RARA fusion transcript. There are 3 breakpoints that can happen in the PML. PCR1 happens in the intron 6, PCR2 in the exon 6, and there is a short isoform called as BCR3, which occurs due to a break in the intron 3 of the PML gene. So it is important to know these isoforms because they correlate with the TLC at presentation, and as we'll go on to see how that increased TLC plays a role to complicate the matters in. So this PML RARA fusion product, this is an interesting product because PML gene normally binds to the retinoic acid receptor, and when there is RAR is not bound by its physiological ligand, it leads to binding of RAR alpha to PML, leading to recruitment of the co-repressor complexes. However, in APL, in the PML RARA fusion product, the binding of RARA and PML becomes stronger, such as the physiological doses of retinoic acid, they're not able to dislodge this binding. So these co-repressor complexes become very dominant and they block the subsequent transcription of these myeloid differentiation. Hence, there is a block in the differentiation. In addition to that, PML is normally located in the nuclear bodies. If that is disrupted, there is reduced DNA repair and an increased self-renewal capacity. In addition to that, it also disrupts the p53 axis, leading to reduced apoptosis and reduced senescence of the cell. There can be multiple partners of the RARA gene, and nearly all of them are sensitive to ATRA and arsenic trioxide, except for a few variants, which are highlighted here. The key concern that we see in APL is the coagulopathy, and we'll hear more about it in the subsequent part of the CGR today. It is associated primarily with the expression of annexin 2 on the APL cells, in addition to the usual pathways of activation of coagulation. I would like to end my part here by saying that early diagnosis is key to managing these patients because you do get distinctive morphological findings as well as a very strong MPO positivity in the abnormal promyelocytes. The diagnosis may sometimes be challenging because the patients have a tendency to present with leukopenia and cytopenias. It does have a classical immunophenotype to a large degree. However, we require to demonstrate the PML-RARA fusion by either cytogenetics, FISH, or molecular methods, and workup for coagulopathy and monitoring of coagulopathy is essential for management of these patients. With that, I would like to hand over the mic to Dr. Akriti Khare, who will talk about the diagnosis of APL, the aspects of morphology and flow cytometry.
Good afternoon, everyone. I will be talking about the diagnosis of APML by morphology and flow cytometry. Uh, there are two distinct morphological variants of APML which are common. The classical hypergranular variant. The classical hypergranular variant, which has got the abnormal promyelocytes with large round or oval nuclei and abundant eosinophilic granules, with some of the granules even obscuring the nucleus. There is a characteristic appearance of a faggot cell which is present. When faggot cell is present, it classically helps in the clear-cut diagnosis of APML. A faggot is a cell with the presence of multiple OR rods. This is a faggot in which there are multiple OR rods. More than 3 OR rods are present. So this definite classical hypergranular APL morphology. Apart from that, there is another variant which is the microgranular or the hypogranular variant. This hypogranular variant has got some microscopic granules. Therefore, on the microscopic examination, the cells are having a irregular buttock-shaped nuclei and with a basophilic cytoplasm, and the granules are not visible on the microscopy. On careful examination, some of the cells might show granules. Closed differential diagnosis of this is the monocytic leukemias. As soon as we see the classical morphology of APL, we alert the clinician that we are suspecting a APM so that the early treatment can be initiated. On cytochemistry, there is a characteristic very strong positivity, granular positivity with granules even obscuring the nucleus. This is often called as burst positivity. This is characteristic of APL, and it is not seen in the monocytic leukemias which are a closed DD. So if we are able to diagnose it on the basis of morpho and cyto, apart from that, there are certain other clues for early diagnosis, like in the routine automated counters in the Adware 2120I channel, the characteristic peroxidase channel. This is a case of a hypocellular APL in which we can see a characteristic very strong MPO positivity on the peroxidase channel. This is a case of a hypercellular APL in which very strong APO positivity can be seen. Mostly the microgranular variants which are having high TLC, but on morphology the granules are very few or they are not visible, but the submicroscopic granules can be highlighted on the peroxidase channel of the MPO. So now this is the next fluorescence flow cytometry which shows a characteristic teardrop pattern. The very strong MPO positivity on the peroxidase channel, and this is the teardrop pattern which is present on the next counter. There are certain findings which are give clue that we are dealing with the APML and the immunophenotype. So the characteristic plots on the CD45 side scatter plot, it shows a teardrop pattern. This is the teardrop pattern which is present because of the high side scatter. On the CD117 CD34 plot, most of the APL are CD34 negative. CD117 is positive. HLA-DR is characteristically negative in APL. MPO shows a very strong right positivity. 33 is strong and 13 shows a heterogeneous appearance. 14 is negative and 64 shows a dim positivity. On 11B and 11C, we can see that on 11B, all the cells are 11B negative. So this is very characteristic of APL that all the cells are 11B and 11C negative. A very important point which is there is that the APL cells show a very high degree of autofluorescence. Always the positivity should be interpreted on the basis of the unstained controls. Microgranular pattern shows higher percentage of cases which are CD34 positive, CD2 positive or CD56 positive. Combination of absent HLA-DR, CD11C and 11B are highly informative with almost 100% sensitivity to the APL. The data of the APL flow cytometry in the Department of Haematology in last 1 year. Of the 17 cases, CD34 was positive in 41% of the cases. CD33 was positive in 100% of the cases, and CD117 was positive in 64% of the cases. HLA-DR showed a high sensitivity with 88% cases showing a negative HLA-DR, and CD11B and 11C was negative in all the cases. Now I will like to invite Dr. Ashish for the uh, molecular part.
Good afternoon, everyone. I'll be talking about acute promyelocytic leukemia diagnosis by cytogenetics and other molecular methods. So as you can see, the classical promyelocytic leukemia, there is a translocation between long arms of 15 and 17, and is a metaphase spread from a bone marrow sample. You can see there's a translocation, reciprocal translocation between chromosome number 15 and 17, and you can see there's a larger chromosome number 15, which suggests there's a translocation. Also, the diagnosis can be made by fluorescence in situ hybridization. This can be done by a dual color dual fusion technique or a break apart phase. In a dual color dual fusion phase, we use two probes for PML and one for RARA. Whenever there is a fusion between PML RARA, one yellow signal can be there apart from two normal signals. However, break apart phase, whenever there is normal RARA, no rearrangement of RARA gene, there will be a normal signal which is yellow here. Whenever there will be a break apart, two different signals, one red and one green signal can be seen. However, there are some disadvantages of cytogenetic diagnosis as karyotyping. The conventional karyotyping is time taking. It needs a good quality metaphage. Cryptic translocations cannot be diagnosed by conventional karyotyping. Fluorescence in situ hybridization though has a shorter turnaround time, but still it is difficult in a low count setting. And many abnormalities like derivative 17 may not be detected by FISH. Very large FISH probes may miss small rearrangements, and no isoforms of BCR1 or 2 or 3 can be identified by fluorescence in situ hybridization. Acute promyelocytic leukemia is a medical emergency due to its coagulopathy symptoms. So early diagnosis saves lot of lives. So this study was done in Department of Haematology. So as you can see, in this study we have used PGM3 antibody and analyzed it on a immunofluorescence microscope. 36 newly diagnosed acute promyelocytic leukemias were recruited. As you can see, the sensitivity and specificity of almost 94% and 92% to diagnose APL. In normal cells will show the promyelocytic leukemia gene as nuclear bodies. However, in case of APML, a microspeckling pattern can be seen, which is diagnostic of acute promyelocytic leukemia. More importantly, this technique is cheap with a shorter turnaround time of just 2 hours. However, the gold standard approach to diagnose acute promyelocytic leukemia has been RT-PCR or reverse transcriptase PCR. Because of its high specificity and sensitivity, also it can identify the PML transcripts or isoforms, namely BCR1, 2 or 3, and turnaround time is also short, is just 2 days. In our department, we extract the RNA from peripheral blood or bone marrow. Then we check the RNA quality and quantity on a nanodrop technology, and then a cDNA or complementary DNA is synthesized from the template RNA. Then we can proceed to either reverse transcriptase PCR, which is a qualitative PCR, or a RQ-PCR or real-time PCR, which is a quantitative PCR. In case of a qualitative reverse transcriptase PCR, we use two primers, a 5' and 3' primer, respectively for PML and RARA genes. After the PCR amplification is done, those amplicons are run on a 2% agar gel to find out positivity or negativity. Here you can see a positive control for BCR1 isoform shows a 381 base pair band. Similarly, the tests are also showing a 381 base pair band, so confirming the BCR1 isoform of PML RARA. RQ-PCR has been the standard method for molecular monitoring in many AMLs, including acute promyelocytic leukemias. Also, NCCN guideline highlights the importance of RQ-PCR to do it post consolidation, and also intermittently up to 2 years to find out early relapse. RQ-PCR is less prone to contamination. It gives better assessment of disease kinetics and gives earlier detection of molecular relapse. Here are some papers which were published from Department of Haematology. So in these two papers, we found out that BCR3 isoform is more frequent than BCR1 isoform, unlike the studies done in Western countries where they found out that BCR1 isoform is more prevalent or more frequent up to 60% of cases. Then in these two studies published from our department, we studied the FLT3 ITD mutations in acute promyelocytic leukemias, and we find out that FLT3 ITD mutations were more frequent in acute promyelocytic leukemia cases compared to non-acute promyelocytic leukemia AML cases, and these FLT3 positive cases showed a significant higher TLC. Post-induction complete remission rate was lower in FLT3 mutated APL cases, and FLT3 ITD mutated cases had a higher early death rate. Now I'll invite Dr. Rama to talk about coagulopathy in acute promyelocytic leukemia.
Thank you, Dr. Ashish. Continuing with the talk, patients of APML are known to have an increased risk of bleeding, which is the leading cause of death, as well as thrombosis, which is underreported but seen in up to 10% of patients. Balance, however, may tilt any time from bleeding to thrombosis. In the pre-ATRA era, the mortality rate was reported to be up to 30%. However, with the discovery of ATRA, the mortality rate has come down significantly. Risk factors for bleeding are an elevated WBC count, low fibrinogen levels, poor performance status, and elevated creatinine levels at presentation. However, these studies found that platelet counts were not predictive of bleeding diathesis in APL. So, how different is APL coagulopathy from DIC? In APL, there is no microvascular thrombosis. Fibrinogen is markedly low. The platelet half-life is normal. There is only mild prolongation of PT and APTT in comparison to DIC, and the levels of circulating anticoagulants such as protein C, S, antithrombin, and TAFI are within normal limits. All parameters in APL are not necessarily abnormal, and bleeding does not correlate with hemostatic abnormality. Coming to the pathophysiology, coming to the bleeding part, the main thing that leads to bleeding is hyperfibrinolysis, which is the most common cause leading to bleeding in APL, followed by other causes like consumptive coagulopathy, proteolysis, and thrombocytopenia. Thrombosis is caused due to release of cancer procoagulants, tissue factor expression, as well as release of cytokines. This is a simplified model of a leukemic promyelocyte, which shows the bleeding pathway, wherein what we see here is an increased expression of annexin A2 on the surface of promyelocytes. This increased expression leads to hyperfibrinolysis by activation of the fibrinolytic pathways via tissue plasminogen activators, leading to an increased production of D dimers and FTPs. In the thrombotic pathway, we have activation of coagulation due to an increased expression of tissue factor on the surface of these leukemic promyelocytes that activate the coagulation cascade via factor 7 activation, leading to the production of fibrinogen D dimers and an increase in the fibrinogen degradation products. In addition, cancer procoagulants and cytokines such as interleukins and TNF alpha are also known to have a role in endothelial activation and coagulation. So, viscoelastic assays in APL, can they improve assessment of hemostasis? This is a typical thromboelastogram plot, which shows the coagulation as well as fibrinolytic pathways in real time, which can be measured by various parameters like R time, K time, alpha angle, MA, etc. Now, in a study conducted by our department in 45 patients of acute leukemia, we had 13 APL patients, as in the TEG, which was conducted in our department. APL patients comprised 13 in number, while TEG was performed in 32 AML patients. Platelet counts were found to be reduced in the APL group as compared to the AML group. When we look at the bleeding score, both the major bleeding as well as minor bleeding, there is a clear-cut difference between the APL group as compared to the AML group, with a near a borderline statistically significant p-value in as seen here. Also, when we look at the bleeding-related mortality, the p-value is statistically significant because bleeding-related mortality was seen only in the APL group and none of the patients in the AML group. So, comparing two cases, one patient of APL with epistaxis and hematuria versus another case of AML with petechiae, which comes under WHO grade 1 MJ, or WHO grade 1 scale. So, both these patients had similar screening coagulation parameters. The platelet count was also comparable in both these patients. The D dimers were elevated in both the cases. But in the patient of APL, what we see is a reduced MA and a reduction in the alpha angle, along with a markedly increased K time. So all these are pointers towards a hypocoagulable state. Whereas with similar screening coagulogram values and comparable platelet values, what we see here in a patient of AML is a near normal MA value and a slightly elevated alpha angle. So this plot with comparable screening coagulogram values in a patient of APML would probably help us to predict bleeding risk better in APL patients. Now, another patient of APL who had thrombocytopenia with hypofibrinogenemia, who had normal screening coagulogram parameters along with an elevated D dimer level. We can see a similar plot here, which is explained by we have reduced MA value, which can be explained by thrombocytopenia and hypofibrinogenemia. However, in addition to bleeding manifestations in this patient also had an intracerebral thrombosis. So probably there are other local factors also at play, and larger studies are probably required to predict bleeding risk in some subgroup of patients. Coming to the individual TEG parameters, APL patients in the APL group, K time was found to have a statistically significant p-value as compared to the AML group, and also the alpha angle was found to be reduced in the APL group as compared to the AML group with a statistically significant p-value. The maximum amplitude also found to be reduced in the APL group as compared to the AML group, but did not show a statistically significant correlation. Now, I would like to call upon Dr. Mukul to discuss the treatment overview of APL.
Thank you, Dr. Rama. I'd like to discuss about the treatment overview of acute promyelocytic leukemia. If we look at this graph beautifully highlights how the APL was described in 1950s, somewhere in the middle of last century, as a pathological entity with a rapid downhill course and a high bleeding tendency. Now, from that part, it has improved to almost or a highly curable disease in the current era. Between these time points, there was a discovery of translocation 1517 in the 1970s, and the early part where APL was treated like other acute myeloid leukemias with the 3-7 or a daunorubicin plus cytarabine kind of induction therapy. Subsequently, as the pathogenesis of APL was discovered, targeted therapies came into being, and first use of all-trans retinoic acid in APL therapy was described in 1985. After that, ATRA or all-trans retinoic acid was combined with chemotherapy in 1997, and subsequently in the early 2000s, arsenic and ATRA-based combination came into existence. These are the most commonly used therapy used in the current era. Nowadays, one of the targeted monoclonal antibody, gemtuzumab ozagamicin, has been used in high-risk APL cases since the early 2010. And of late, oral preparations of arsenic trioxide have also come into existence and are being tried in various clinical trials. If we look at the clinical features of APL, we see that APL is more common in adults without any sexual predilection. It more commonly present with pancytopenia and the subsequent features with severe pallor and predisposition to infection, both bacterial and fungal infections. There is a high proportion of major bleeding, including life-threatening intracranial or parenchymal bleeding. This bleeding usually does not correspond to the platelet count or the routine screening coagulogram which we perform. Occasionally, thrombosis has also been described in the patients. Lower limb thrombosis, pulmonary embolism, and arterial thrombosis all can occur. Rarely, patients can be asymptomatic or present with only minor skin bleeds or epistaxis. Historically, APL has been characterized by SANS risk criteria as high risk or low risk, depending on the WBC count of the patient. If the WBC count is more than 10,000, it is classified as high risk, and if it is less than 10,000, it is classified as low risk. We discussed the treatment aspects of APL. This will be incomplete without the discussion on the mechanism of all trans retinoic acid and arsenic trioxide, which are the targeted therapy for this disease. If you look into the graph, both these drugs they act by inhibiting the basic the pathological entity in this APL, which is the PML-RARA transcript. So, all trans retinoic acid it causes the terminal differentiation of the abnormal promyelocytes, and arsenic trioxide it acts by three mechanisms. It causes the differentiation of the promyelocytes, it causes apoptosis of these abnormal promyelocytes, as well as it causes the clearance of the leukemia initiating cells. If we go into slightly deeper into the mechanism, we see that ATRA binds to the RARA moiety of the PML-RARA transcript. As a result, the co-activator complexes are recruited, which leads to transcriptional depression of target genes and degradation of PML-RARA via proteasomal pathway. Ultimately, what happens is there is reversal of the differentiation block and terminal myeloid differentiation ultimately occurs. Arsenic, it binds to the PML-RARA moiety of the transcript, and by various mechanisms, it leads to the degradation of the PML-RARA, and as well as it also eradicate the self-renewal capacity of the leukemia initiating cells. So whenever we have a suspected case of APML, we should remember that this is a medical emergency. Patient can be salvaged with early initiation of therapy and supportive care if they are started within hours or within the first few hours of uh, even the suspicion of diagnosis. So whenever you have a suspected case, a pancytopenia case with abnormal cells in the peripheral smear, and a pathologist report it as a suspected acute promyelocytic leukemia, you should start the patient on directed therapy as well as supportive therapy simultaneously. Start the patient on ATRA at the first index of suspicion and immediately arrange for the blood products, platelets and fibrinogen as appropriate. Patients are to be arranged for PRP or SGP transfusion to maintain a platelet count of more than 30,000, or fibrinogen concentrates or FFP or cryo to maintain a fibrinogen level more than 180 milligram per deciliter. Classify the patient as SANS low risk or high risk. Consider prophylactic steroids in the patients with high risk APL. If the patients are of high risk APML, you should also consider the patient starting them on early anthracycline based therapy within first 1 or 2 days of the diagnosis. At the same preset, start the patient on tumor precautions with adequate fluids and allopurinol. Look for infections. Give the patient prophylactic or therapeutic antimicrobials. Unlike other acute leukemias, we should avoid putting central lines in these patients in the first week. Avoid lumbar puncture or leukophoresis. While the patients are on therapy, the aim should be of a good electrolyte control and intake output balance. Maintain potassium more than 4 milliequivalents and magnesium more than 2, and always monitor the patient for differentiation syndrome and other complications related to therapy. So, in the current era, if we see that low risk APML are treated with a combination of ATRA and ATO. If arsenic is unavailable, you can treat the patient with ATRA and chemotherapy based protocols. In the high risk patient, they are treated with a combination of ATRA ATO plus gemtuzumab if available, or if that is not available, with the anthracycline, either idarubicin or daunorubicin. If both these drugs are not available, just continue the patient on ATRA and chemotherapy based protocols. After around 4 weeks of this initial therapy, patients are assessed with the bone marrow examination, and as these therapies are highly effective, almost 95 to 100% patients undergo remission, and the blast or the abnormal promyelocytes are clear from the blood and bone marrow. After this, the patients are started on arsenic and ATRA based consolidation therapy, which is essentially consisting of giving weekly pulses of all trans retinoic acid and monthly pulses of arsenic trioxide. These cycles are given for around 4 months, followed by maintenance therapy in high-risk cases. The long-term prognosis of these patients is very good. However, around 10% of high-risk cases may relapse and few cases of low-risk APL may relapse. In such a scenario, if uh, arsenic atra-based therapy has been used previously, these patients can easily be salvaged with the arsenic and chemotherapy-based protocols or vice versa. And when they go into molecular remission, they can be considered for an autologous stem cell transplant. The complications of the therapy and the underlying disease are important to monitor for, especially in the first month of therapy. The problems of coagulopathy leading to bleeding or thrombosis cannot be highlighted further. They will be discussed in further details subsequently. And a special complication, that is differentiation syndrome, occur in a good proportion of patients and can be fatal in some of these. Then there can be therapy-related problems related to arsenic or atra, which we'll be discussing subsequently in our talk. Now I'd like to invite our DM resident, Dr. Tejaswini, to discuss our AIIMS data on the therapy of APL.
Thank you, sir. I'll begin with our demographic data. To the left, we have our departmental data from 2008 to 2012, which was published in 2015 in Indian Journal of Cancer. And to the right, we have our recent unpublished data from 2016 to 2020. We had 34 patients of APL diagnosed between 2008 and 2012. The median age was 30 years, with 53% being males and 47% being females. The median WBC count was 4,160. 58% patients belong to the SANS low risk category and 41% patients belong to the SANS high risk category. 50% of the patients presented with baseline infections and 91% developed infections while on therapy. If we compare this to our recent data, we had 64 patients between 2016 and 2020 with the median age of 28, 40% being males and 59% being females. The WBC count, median WBC count was 9,000 and 50% belonged to SANS low risk and 50% to SANS high risk. Baseline infections were seen in 57% patients and infections during therapy were present in 62% patients. If we compare this to the Western data, we have a significantly higher percentage of patients who present in the SANS high risk category, who have a greater chance of relapse. And as compared to the corresponding Indian data, we have a similar rate of baseline infection as well as infection during therapy. Although if we compare our old data and the new data, we have improved on the infection rates from 91% to 62% during therapy. Since prior to 2017, all our patients received atra plus daunorubicin, irrespective of the risk stratification. From 2008 to 2012, all our patients received the same therapy. However, with the discovery that arsenic trioxide results in survival benefit in patients with APL, 27 onwards, SANS low risk group patients in our hospital received atra plus ATO, whereas SANS high risk group preferably received atra daunorubicin with or without ATO. As we can see here, among SANS low risk patients, most patients have received atra ATO. Some received atra plus daunorubicin. This was mostly in the early 2017 when we were still shifting our protocols. In the SANS high risk category, most patients have either received atra dono ATO or atra plus dono. And some patients have received atra plus ATO. These were mostly patients in whom we wanted to avoid giving daunorubicin, either because of cardiotoxicity or because patients had an infection in baseline and we wanted to prevent further neutropenia. There are 5 patients who did not receive, who basically received atra with some varying doses of hydroxyurea or low-dose cytosol. We mostly lost these patients in the first 1 or 2 days and we couldn't start them on a particular protocol. Complete remission was achieved in all patients who completed induction, that was 75%, and there was no difference in induction outcomes in low risk or high risk. As we can see here, 84% patients in the low risk group achieved induction remission and 65% in the high risk group went into remission. There were 15% deaths in the low risk group and 31% deaths in the high risk group. This difference was not statistically significant. 1 patient in the high risk group went LAMA and this data was censored at the date of discharge. Coming to the induction outcomes again, as we saw that patients who completed induction, that was 75%, all of them went into remission. Among the 23% deaths, 9 deaths were because of infection, 6 were because of bleeding, and 1 was because of differentiation syndrome. If we compare this to the Western data, they also quote the same reasons as the most common cause for mortality during induction. However, they have a lesser incidence of infections during induction. And in a multivariate analysis in our recent data from 2016 to 2020, we noticed the development of infection during induction was a significant predictor of death. Coming to our event-free survival, between 2008 and 2012, our EFS for 4 years was 64.5%. Over time, we have improved upon that, and our recent data shows the EFS for 4 years to be 71.25%. If we have a look at the comparison between high risk and low risk, as we can see here, there is no significant difference between the two risk groups in the earlier data. But over time, there is a stark difference between the low risk and the high risk. The EFS in the low risk one is as high as 84.3%, whereas in the high risk one is 58.3%. And the difference is significant with a p-value of 0.026. Possible reasons for this improvement include: 1, shifting to an ATO-based regimen, also removal of daunorubicin from induction, that meant lower exposure to neutropenia and infections, and also improvement in our infection rates probably contributed to this. Coming to the relapses, when we combined the two groups, we had 6 relapses after therapy. 1 patient had a CNS relapse. Of the 3 patients who expired, 2 expired secondary to an IC bleed. 1 patient expired due to sepsis with multi-organ dysfunction. 2 patients underwent auto transplant in CR2, and of these 2, 1 patient unfortunately relapsed at 9 months post-transplant. I now invite Dr. Sahitya to discuss the complications in APL.
Coming to the complications, first and foremost, we should all be aware of a syndrome called differentiation syndrome, which is seen in majority of our patients when they started on therapy initially. So it is basically a cytokine mediated syndrome, which is seen after initiation of therapy with differentiating agents. However, rarely, it can also be seen spontaneously prior to initiation of therapy, and in cases of ATO, it can occur in the 3rd to 4th week. That's called late differentiation syndrome. Usual median onset of symptoms is between 3 to 7 days after initiation of therapy. So the risk factors associated with differentiation syndrome include SANS high risk, pre-existing organ dysfunction, and absence of steroid prophylaxis. Common clinical features which we encounter when we should be aware of when we are suspecting a differentiation syndrome include fever, weight gain, hypotension, respiratory distress, renal failure, and effusions, both pleural and pericardial. So this is a pictorial representation of differentiation syndrome. So once we initiate these patients on ATO and ETRA, the abnormal promyelocytes differentiate to myelocytes and metamyelocytes, causing release of cytokines, causing a differentiation syndrome. The abnormal cytokines involved in APL differentiation syndrome include interleukin 1, 6, interleukin 8, and TNF alpha, causing a systemic inflammatory response syndrome leading to fever, tachycardia, and increased vascular permeability. There is also release of cathepsin G, which causes increased vascular permeability and endothelial damage, and also increased adhesion of blasts can lead to leukostasis, endothelial dysfunction, and organ infiltration. So the symptoms of weight gain, effusions, pulmonary edema, and distributive stroke are predominantly attributed to increased vascular permeability, and organ endothelial damage leads to organ hypoperfusion and ischemia, leading to multi-organ dysfunction. So these are the representative chest X-rays of a patient who presented with APL on initiation of therapy developed severe differentiation syndrome. As we can see numerically, there is increased bilateral symmetrical chest infiltrates, and once we've initiated the patient on steroids and ATO and ETRA with withhold along with aggressive supportive care, the infiltrates have disappeared and the patient had recovered from differentiation syndrome. So is there a way we can prevent differentiation syndrome? Yeah, there were studies which code for steroid prophylaxis in high-risk cases. We usually use prednisolone at 0.5 mg per kg per day, which we can consider in high-risk patients. Coming to the grading of differentiation syndrome, it depends on the number of clinical features present in our patients. Usually severe is more than or equal to 4 features, moderate is 3 features, and if there are less than 3 features, we need to rule out other mimickers of differentiation syndrome. So once we have a clinical suspicion of differentiation syndrome, we need to start these patients on empirical dexamethasone, which is at 10 mg every 12 hourly, and in severe cases, we might have to withhold the therapy with ATO and ETRA. There's a very important thing along with these two is an aggressive supportive care, which includes oxygenation and, if required, mechanical ventilation, appropriate fluid management. We should always avoid a positive fluid balance, which can lead to further worsening, and we need to maintain adequate urine output, and if required, we need to put these patients on renal replacement therapy. Along with this, coagulopathy should be managed appropriately, and with aggressive clinical support, differentiation syndrome can be tackled. Otherwise, it's a life-threatening emergency, and we need to regularly monitor all our patients for differentiation syndrome. Once the differentiation syndrome settles, steroids can be tapered and ATO and ETRA can be restarted again. Like I was talking earlier, we need to also rule out other mimickers which need to be considered in these patients, which include infection, pulmonary embolism, diffuse alveolar hemorrhage, congestive heart failure, and other causes of renal failure. So coming to our data on differentiation syndrome, in the previous cohort, from 2008 to 2012, out of the 42 patients, 44% had differentiation syndrome. In our recent cohort, which comprised of 64 patients, 56 patients had differentiation syndrome. So coming to this pie chart, of the 56% who had differentiation syndrome, 61 patients belong to SANS high risk and 39 patients belong to SANS low risk. So steroid prophylaxis was given in 19% of our high-risk patients. Severe differentiation syndrome was seen in 72% of our patients. And mortality attributing to differentiation syndrome was seen in 2 patients, one from the previous cohort and one from the recent cohort. So coming to the next important complication which we all encounter while managing an APL patient is coagulopathy, of which bleeding, this is the data from the recent cohort. Bleeding was present in 83% of our patients at presentation. Of the 83%, 25% had major bleeding, which included intracranial bleed, gastrointestinal bleed, and pulmonary bleed. So out of the 13 patients, 7 patients had a gastrointestinal bleed in the form of melena and hematemesis. 4 patients had intracranial bleed and 2 patients had a pulmonary bleed. Mortality secondary to bleeding was seen in around 40% of our patients. A special focus on intracranial bleed. We all know it's quite common in our patients and it's associated with high induction mortality. So over the past 1 year, there's a study going on to look at intracranial bleed at baseline. So we were getting a CT scan of brain at baseline, and it was found that 13 patients at baseline had intracranial bleed, of which 3 patients were completely asymptomatic and intracranial bleed was picked up on a CT. After initiation of therapy, 2 more patients had developed intracranial bleed, which was aggressively managed with platelets and FFP or cryo support. The other component of coagulopathy, which we all know in APL, is thrombosis. However, it is not reported as bleeding manifestations. We saw around 6 patients who developed a thrombosis, of which 4 had intracranial thrombosis. 1 patient has a superior sagittal sinus thrombosis, and 1 patient had a right middle cerebral arterial infarct. Management of thrombosis in APL is extremely challenging in view of thrombocytopenia and DIC. We can consider these patients for therapeutic anticoagulation if platelets are more than 50,000 with a high risk of bleeding. Prophylaxis can be given in patients if platelet counts are more than 30,000. So coming to the now therapy-related adverse events, benign intracranial hypertension or pseudotumor cerebri is seen commonly in our patients. Around 17% had reported pseudotumor cerebri. It's more common in females and children. Important differentials we need to rule out are IC bleed, hypertension, and stroke. They usually managed with estezolamide, mannitol if required to decrease the intracranial pressure along with the ETRA dose reduction. So like we've all like it was discussed previously, this is a spectrum of infections seen in our patients and the various foci. Baseline infection was seen in 57% of our patients. Mortality secondary to infections was seen in 60%. Here I would like to highlight that in contrast to the Western data where bleeding is the most common cause of mortality in India, along with other studies, infection is still the major cause of mortality in these patients. Coming to the rare manifestations seen, ETRA desquamation seen in 14% of our patients, which is managed with emollients. Ulceration, scrotal ulcers were reported in 2 patients. Ileal ulcer was reported in 1 patient. Hepatotoxicity was seen in 16%, probably due to various drugs we used during induction. Cardiotoxicity was reported in 2 patients. 1 patient had a PSVT, whereas the other patient had cardiac failure. These are the various case reports published from our institute. Upon initiation of ATO, 1 patient reported an acute flare-up of rheumatoid arthritis. We had 1 case, which was a therapy-related APL after therapy to CA breast. CNS involvement at second relapse was seen in one of our patients, and it was managed with ETRA and chemotherapy. And 1 case report reporting unusual massive bone marrow fibrosis in APL patients following ATO therapy. So, take home points. We all need to have a high degree of suspicion in patients presenting with pancytopenia and severe bleeding manifestations. It is a medical emergency requiring prompt diagnosis and management. Rapid diagnosis with morphology, flow cytometry, and PGM3 antibody can be done. There's an emerging role of viscoelastic methods in associated coagulopathy. Recent protocols are chemotherapy-free treatments with ATO and ETRA as their backbone. Still, till today, the major hurdles in treatment of APL include major bleeding, high infectious burden, and differentiation syndrome. APL is a disease with high cure rates, low relapse rates, with ATO and ETRA as a current backbone.
Excellent seminar. I'm really grateful for you to put all the things together and present it so nicely. And it's really heartening to note that we are making some improvement, and that's why it's important to collect the data. So, what do you think is going to be our next steps in the future to further improve the outcome, especially for the patients where we are losing them to either bleeding or to infections?
As discussed during the presentation, the major cause of deaths in our setting are still infections, which are contributing to almost 60% of mortality in amongst our patients. So, proper and better infection control is very important. Appropriate use of antimicrobials, both as prophylactic agent and subsequently, if required, as therapeutic agents, that is important. Next step is to reduce the initial bleeding. Unfortunately, throughout the world, in the real world, if we see the real world data, the initial or the early mortality, which is described as mortality occurring within first 48 to 72 hours in APL patient, has been almost similar throughout the world, and that is something which can be improved with early initiation of therapy to a certain extent, but cannot be totally eliminated. So whenever we have a suspicion of APL, either at 2 a.m. in the night, start the patient on ATRA. That is something which reverses the coagulopathy early. That is something which we are looking at. There are studies which have now shown that the combination of ATRA and ETO can lead to almost 100% outcome in the low risk APL cases. But the outcomes of high risk APL cases, especially with respect to bleeding, has been nearly in the similar ranges. And early mortality is something which needs further improvement. Perhaps the real world data is kind of similar throughout the world.
So, as everybody knows, the cause of mortality in APML is bleeding manifestation mostly worldwide. But what we have observed, the infection is also another cause of mortality in our settings. The majority of the patients, as you all aware, present with pancytopenia. Okay, so almost by the time they come to our the emergency, they have pancytopenia for this longer for 4 to 6 weeks of pancytopenia. That is the major reason of infections. So, good number of patients present with infections at the time of diagnosis. So that is one. Second point, of course, most of the deaths, if you see during the before starting initiation of therapy, or maybe the first 7 to 10 days of initiation of therapy. So that is the peak time where you can give any, even if it's a high risk patient, you can give proper chemotherapy. The proper treatment was not initiated to start with. That are the reasons for cause of death in apart from bleeding is also infection is one of the major cause that we should.
Many of these patients present with TLC as low, even below 10, below 1000 or as low as 500, 600 with platelet counts less than 10,000. These are very sick patients to present with and are to be, whenever our lab gives us suspicion of APL or even one of two cells which are identified as probable abnormal promyelocytes, you just start the patient early on therapy, these patients. Not much data on that. So, uh, unfortunately, idarubicin is not commonly available, at least in our setting. So, we have substituted that with donovan. I think, I invite you for any final comments on this. I'd like to thank everyone for attending the CGR. Thank you.